all the cases in Kerala are from UAE. Are there some implications to it? I think that both Dr. Prajna and Dr. Himanshu can answer, because some of the issues are related to international travel, and the other is the question. Actually, the author of the question is suggesting is, can there be a potential animal contact? Are we changing the case definition in Kerala? I mean, in the country, NCDs is the case definition that we follow in India, which basically should have skin rashes instead of rashes. Are we making it something similar to WHO? First, shall we get the response from Dr. Prajna?
So for the Kerala cases, so for the it doesn't give any history of involvement of any animals, so I cannot comment. But definitely, all the cases which has been coming to Kerala, they are falling to 8.2 lineages. And the only surprising thing which I feel that UAE has reported very low number of the cases. So I don't know the kind of screening or testing they are doing at the moment, but I'm pretty sure about it that UAE has a large number of circulation of A2 lineages. I think the tracing of these cases actually lie in UAE, and we don't know how to access those information. So maybe I think Dr. Himanshu would be better person here to link the story here. Thank you.
Thank you, madam. Yes, that is a question. We should be looking at it. The reason why we updated the case definition was when we looked at the Delhi case. At that time, there were the Kerala cases which were all reporting international travel history. And then there was this case from Delhi, which definitely did not have international travel history. There might have been some contact with international travelers at some stage, which he was not forthcoming. But later on, when we also saw those Nigerian cases who hadn't traveled, as the passport records clearly indicate, there was a need. We would have definitely missed the first case in Delhi if we had restricted ourselves to the case definition, which requires suspicion on the basis of international travel history. So case definitions keep on emerging. The basic purpose of case definition is to identify as many cases as possible. And the case definition that we have kept, which doesn't require an international travel history, is for screening purpose. Once this screening part is done, then it is to be evaluated by a physician. And that is the crux of whether the decision that is to be taken, if the samples are to be sent for sampling or not. That is on the basis of the clinical ascertainment, whether it is indicating a suspected. And whenever in doubt, from a surveillance and public health point of view, we always say that whenever in doubt, it is better to get tested rather than to presume on clinical basis that it is not a case of monkeypox.
Thank you, Dr. Himanshu. Again, Dr. Sarin's question, whether we should suspect the disease in any case with vesicular papillary lesions, even without a history of travel. And if we need to send a sample in such patients, can we ask them to isolate them in house till the results come?
So the isolation guidelines are clearly mentioned at the moment that if we are suspecting a case, then the case has to be isolated in a designated facility. So that is where the role of the clinician or the dermatologist or the gynecologist who has examined the case comes into play. That the screening part says that it is a suspected case of monkeypox. That's the suspected case definition. But the presumptive case definition is heavily dependent on the clinician's assessment. Because we have seen all kinds of symptoms, even we are looking at a possibility. There are reports that mention that there are no symptoms. Then at that stage, if there is anything which the clinician, in our past experience, we have seen that due importance to the clinician's judgment has probably not been accorded in some instances. And sometimes there is a strong suspicion, because we saw in the case of Delhi, the dermatologist was very much sure based on the presentation that this is a classical case and we need to send the samples. So we did that. So it is a mix that we have taken, tried to balance between what is the clinical presentation and what is the ascertainment by the examining dermatologist.
Thank you, sir. Before taking Anish's question directly, Dr. Vinskari has mentioned about the 50 genetic changes over a small or a brief period of time. In a few sentences, what are the major public health implications of these findings?
Yes, so at this moment, there is the public health implications of the genomic changes are really unknown because we know very little about the monkeypox genomes, even the functions of many of those genes. So largely at this moment, they are genetic changes. The close public health implication that I can sort of come to at this point of time is use this information to build better diagnostic kits because we should not end up building primers onto such genomic sites which are under natural selection.
Dr. Anish T.S. is Associate Professor in Community Medicine. He is a member of the State Expert Committee on COVID-19.
Actually, I have got two questions. One is for Dr. Aravind. Regarding the third case of monkeypox that was detected in Manjeri, it was started with a carbuncle-like lesion in the back of neck, and the typical progression of the vesicles was actually absent. It was a totally atypical case. And we have found that in some of the articles that in the area where in close contact with the skin has got that kind of a lesion in the context of bites with prairie dogs and all. So is it a possibility that if there is a skin contact, especially this patient was reporting that he has admitted many times in a hospital at Al-Ain of UAE, is there is a possibility that this person can contact the disease by a formate transmission? That is my first question. And second question is to Dr. Vinod. As UAE is well connected to US compared to Europe, is there any possibility that the A lineage from US is transmitted through UAE and it is happening in Kerala? And it has got many connotations, as you have, Dr. Vinod has mentioned in some of the articles in Hindu and all. There may not be a sexual transmission in this case. There may be the B lineage may have got a sexual connotation and A lineage may not have. What is the stake on that by Dr. Vinod? These are my two questions. Thank you.
The first part, I showed in the slide that was in sort of an atypical presentation, carbuncle with multiple satellite-like lesion with and without a genital lesion. It was there in the third case. And whether it could be due to formite. So as of now, the WHO document says that 0.8% of the transmission could be due to the environmental and all those things, only 0.8%. What exactly happened in that case, we really don't know. The patient does not give any contact history, etc.
I personally interviewed that patient.
I know, sir.
That patient denies any kind of sexual contact. I do not know how much it is reliable. He gives a clear history as he has admitted in a particular hospital in Adelaide, and he was multiple times he was examined in that hospital. That is why I was asking.
And that's possible, sir, because here in monkeypox, the inoculation lesion is there. That is why anogenital region you are having lesions, orogenital region you are having lesions, etc. In this case, actually, the maximum size lesion was in the shoulder, the carbuncle like thing. So, sort of an inoculation should have occurred there. So, for that to occur, as sir said, one possibility is actually the contact with the linen, etc. So he was admitted multiple times in the hospital, and we know that UAE must be having a lot of cases which are getting missed. So that is possible. But as of now, only 0.8% of the cases are supposed to be due to other routes of transmission.
Dr. Venu?
Yeah, so Dr. Anish, that's a very interesting question. And just to pull up the slide once again, so you did indeed point a very pertinent observation that the Indian clusters at this moment is the closest relative is actually the US sample that was sequenced in 2022. Now, it would also be a bit erroneous at this moment, but nevertheless very distinct from the Thailand clusters that we see. As long as we do have a bit more genomes, even a couple of more genomes from the UAE, we would actually be able to put this cluster in perspective. So at this moment, yes, the closest is indeed the genome from the United States. Nothing is known about the sample, despite having requests gone to CDC from multiple different investigators, not just me, but across the world. Nothing is known about the sample. Now, your second question is whether this would suggest a non-sexual mode of transmission. So if you really go back to the WHO report, approximately 9% of cases, so it's almost like a 91 versus 9% of cases, which do have a known sexual mode of transmission. There are anecdotal evidence, which and even preprints now, which could suggest that hospital-acquired infections can indeed happen to both healthcare providers and anecdotal evidence, not in preprints, which could suggest that individuals could get infections from hospitals. So that is indeed a possibility, but a rare possibility because the sexual mode is probably much more efficient than the non-sexual mode.
Thank you, Dr. Vinu. Dr. Ajit Kumar, I think that can be the last question. Dr. Ajit is Professor of Dermatology from Government Medical College.
Thank you, Dr. Indu and others. Elaborate presentation and follow-up of the epidemic. My question is, we are almost sure that almost more than 90% of infections are sexually transmitted. Only the difference, it's almost 100% sexually transmitted, depends on how you define the sexual transmission. Because very close contact can be sexually or non-sexual also. We don't know exactly it happens. That's true. But the involvement of targeted intervention, which already mentioned, especially in the MSM, is important at this point of time. Recognizing this, and are we planning that in our public health measures to educate our MSM PI groups and MSM groups, especially those who are likely to come in contact with those who are coming from abroad, especially in this country and in the sports of our country, because they are most likely to get the infection with the picture which we see now. So in that case, if we can prevent our people with MSM orientation, can prevent it getting them. Again, remember, condom will not work here. You may have to make some different strategy here. Unless, if you do that, probably we will be able to reduce the impact of the epidemic spreading. Second question I have is, definitely we know UAE has this infection and large number. Otherwise, we will not, with just 16 cases, you cannot get 7 cases here in India. Is there any way we can get what's happening in this country? If we can get, probably that will help us. Especially many of our patients actually got diagnosed in their country, including newspapers, including the patient who died, had a letter or certificate or something saying monkeypox positive. We don't know who he was. He had a certificate like that. That's what newspapers. And he came to India and stayed here. So unless we involve the other countries also.
Okay, that is regarding the Indian policies, right?
Yeah, it's a policy question.
Dr. Himanshu Chauhan, can we have a quick response?
So, quite pertinent questions, both of them. The first question, yes, in the last joint monitoring group meeting that is chaired by DGHS, this issue was discussed, and NACO is a stakeholder in this deliberations. And NACO has been asked to look at a strategy wherein these high-risk groups through TIs can be targeted. You're right. They have the TIs, as you would be knowing. The TIs would have their own mechanisms wherein known partners versus unknown partners and people with travel history and the safe sexual practices are propagated in those close groups. So NACO is right now examining as to how it can form up that strategy. Ultimately, as I also suggested, that the surveillance of this particular condition would have to be owned up by a specialized agency, as these cases do not present in the community as the others do. So that's about the MSM group and the TI's role in that. The second part about what's happening in these other countries, it is a concern which is very genuine, especially in Kerala, where you have all the 5 cases coming from UAE. So it becomes very important to ascertain what's happening in UAE. This issue has been taken through the route of international health regulation. The national focal point, NCDC is the national focal point for India for IHRs. And the IHR national focal point in UAE has been approached. It has also been taken up through diplomatic channels. The Ministry of External Affairs has to share information on what is happening there, or what is the updated on a continual basis sharing of information. And WHO has also been requested to share regular updates about the situation over there.
Thank you, Dr. Chauhan. We have a wonderful panel discussion coming up, which will again deal with some of these questions. Finally, Dr. Neto George, again, that is one of the questions that was asked earlier, because when people are to be isolated in hospitals, there is some stigma involved. Is there any move from the Government of India side to move to home isolation? Should we isolate all the positive cases in the hospital, or can we follow the national guidelines that mentions a provision for home isolation? That is Dr. Neto's question. I think with that, we'll move to the panel.
At the moment, since there's only limited number of cases, so it makes sense that they are fully followed up. It's not just about isolation, it's about following the clinical course in a more supervised way, taking samples regularly, the research part of it. So it makes sense when we are looking at designated facilities to isolate this limited number of cases. But at some stage, if we are looking at transmission channels more concretely known and more number of cases, then it would probably be better to have home isolation options as well, if permitted.
Thank you, Dr. Himanshu Chauhan. Thank you, Dr. Pragya Yadav, Dr. Himanshu Chauhan, Dr. Aravind, and Dr. Vinod Skaria for the excellent presentations and interactions. We move on. Actually, the panel is going to continue the issues that are being raised in the initial talk, and we have a wonderful panel. Dr. R. Ramesh is the Director of Health Service. He is currently the Project Director of Kerala State AIDS Control Society. Dr. V. Meenakshi is the Additional Director of Health Service, Public Health Kerala. Dr. Ajita is the District Surveillance Officer of Kollam. Dr. Anuja is the State Feed Cell Coordinator. Dr. Anuja Elizabeth George, Professor and Head Dermatology at Government Medical College Trivandrum. Dr. Manjushree, who is the Head of Microbiology at Government Medical College Kollam. Dr. S. Nandakumar, who is the Assistant Director, Kerala State Institute of Animal Disease, Palud, who will discuss some of the animal-related issues that has already come up. And Dr. Gina Ramesh is the Assistant Professor in Community Medicine at Government Medical College, Kollam. And we have Dr. Senior Nujum, Associate Professor in Community Medicine and the Regional Feed Cell Coordinator at Kollam to moderate the panel. Senior.
Thank you, Indu Madam. Am I audible?
Yes, you are.
Respected ACS Asha Thomas Madam, the Directors of Medical Education and Health Services, Principal Leonard Madam, Indu Madam, and a warm welcome to all the panelists. At this very late hour, our panelists have been waiting for quite a long time, so I think I will keep my questions short and crisp and just facilitate their talk. So, Madam has already introduced the panel, so shall I call upon Ramesh sir? Ramesh sir has been introduced. Sir, are you there? Sir,
Yes, I'm here.
Sir. Sir, all of us have heard that that how disproportionately a risk group has been affected, particularly the men having sex with men and other such groups. So, sir, and we have Dr. Rajit, who raised the issue of the strategies that should be adopted among such communities. And Himanshu sir has also spoken to us about it. But I'm sure Ramesh sir will have quite a lot to say because he has been working with KESACs. He's on the lead role for quite a long time and very closely interacting with such groups. And he has already started working on such issues. So, sir, could you tell us about the strategies adopted and plan ahead? So, because our panel speaks on the roadmap. What is the plan ahead to protect our MSM communities and others at risk? And second question is, how do we address this very tricky aspect of stigma associated with the disease in such communities, while we also see that this stigma is not a problem in the general community? Over to you, sir.
Thank you, Dr. Senior. Good evening, all. And since it's too late, I'll not be taking too much of time. As already pointed out here by the eminent speakers who have already spoken, that there need to be an integration of the National AIDS Control Program with the IDSP. There's no doubt about it, because the reports worldwide coming says that the incidence of monkeypox is more among the high-risk groups, especially the MSM community. So naturally, we have a very robust mechanism under the National AIDS Control Program throughout the country, and even in our state, we have this targeted intervention projects, which looks after these high-risk group communities. And these targeted intervention projects have been devised mainly for the behavioral change communication among this community. When I say community, it is this HRG community. And also creating an enabling environment with the community involvement and participation. And also linkage for testing and the treatment centers. And to enhance the risk perception and also prevent risk in the HR. So fundamentally, the TI projects or the targeted intervention projects are working on these aspects.
So in Kerala, we have 64 targeted intervention projects, of which 20 are FSW and 13 MSM. So now our focus has come on MSM because the reports coming from all the reports says that the MSMs are more vulnerable now. Definitely, we have already started working on it. When the case that was reported in Kerala, we have an action plan, and our focus on communication with all these HRGs is for the risk associated with the close contact, including sexual contact, in the context of this monkeypox. And also, we are enlightening these HRGs about how to prevent. And also, we are also teaching them what are the early signs and symptoms so that they can report immediately. And also the importance of isolation and timely treatment. And the most importantly, last but not least, and the most important aspect is need for avoiding sexual contact with persons having symptoms of monkeypox or who gives a history of being in contact with the case, and also the importance of reducing the number of clients. And also we have told them, because all these high-risk groups, especially the FSWs, the MSMs and the transgenders, they are already in the sex trade. So however we definitely be in sex trade, there's no doubt about it. That's what we have seen from the experience of the HIV program. So what we have told them is, in the context of monkeypox, when you have a client, just ensure that they are not. There's no history of travel from the country from where these cases have been reported, and also if they have a contact. So we have done a lot of orientation programs through our project state level, also at the district level. We all know that the targeted intervention project, they have the program managers are there, the outreach workers are there, the peer educators are there, the counselors are there. So all these people have been trained, and it's not that easy to bring these HRGs into a platform or into a classroom for an awareness session. So we are utilizing the same thing what we are doing in HIV program. We are reaching to these MSMs through the HRG sites through the peer educators whom we have trained, and also through their WhatsApp or the other social media network. We have been giving them a lot of information about this. So definitely we are worried because in Kerala we have MSM activity increasing over the years. And when we see the HIV data, even though the state has a low prevalence of HIV as far as when compared to the other states, but still the incidence of HIV in MSMs is on the rise for the last few years in Kerala. So in the context of this monkeypox being reported among MSMs, definitely we have moved ahead in creating awareness among these MSMs. And we are using the community-based organizations to reach out to them. One thing. And second thing is, we have also designated STI centers where a lot of sexually transmitted infection cases report. We have 23 centers in our state. We call them Pulleri Kendra. They are all situated in general hospital, district hospital, medical colleges, and taluk hospitals. So we have also instructed the medical officers to have a good physical examination of all these people who are coming and attending our STA clinics, especially the MSMs. We are specifically asking them to definitely have a look at their anorectal regions, so the screening. And we are also trying to catch the young MSMs because we are worried. Because even the previous speakers have said the younger people are more prone. Probably the experts may be having the reason. Maybe if at all the smallpox vaccine is giving some immunity to the monkeypox, but we know that the very young people might have not got that shot. So they are vulnerable. So definitely we are looking into all these aspects to reach out to these MSMs. So I think as Dr. Chauhan has rightly pointed out, in monkeypox issue, the routine surveillance in the community may not be sufficient. There has to be a very integrated surveillance with the NACP program, with our targeted intervention. We have already started it. We have already had a state level and the district level meeting with the DSOs at each district. So our district AIDS control officers and the DSOs, along with the TI projects, are working on a day-to-day basis for the surveillance as well as creating awareness among the MSMs. So these are the things as far as what we are doing on MSM. The second question asked to me was about the stigma. Definitely is a very tricky situation. Even in HIV, I've seen a lot of stigma and discrimination, even though it's not even more than 4 decades, but still that stigma and discrimination has not been totally wiped out. Here again, we have to be very cautious. In case of monkeypox, if we attribute largely the mode of transmission to sexual transmission, I'm afraid that many of them may not come forward for reporting, and they may not come, or that will be an issue. So when we give our IEC communication, the messages, we are very careful in wording these messages, saying that sexual, of course, we will say the mode of transmissions are these and this. So having a very close contact with a known case or a contact of a case will put you into risk for contracting this infection. So we club the sexual mode to a very close contact. If you only say it is sexual transmission, definitely that stigma will come. And in HIV, we could say that any HIV patient, there's no need to stigmatize or discriminate, because you can only get HIV if you have a sexual contact with him, or take his blood, or use the shared syringe or needle. But here we cannot say, and so no other way it will be spread. We can say, we used to say in HIV that you eat together, you hug each other, you play together, you work in the same office. It's not, the HIV is not going to spread. So that is the words we used to use to end the stigma and discrimination. But it's a very dilemma situation here in monkeypox, because we cannot say that. Because we know that monkeypox can be transmitted with a very close contact to the respiratory droplets and close contact, skin to skin contact, everything. So it's a very tricky situation, but we are very cautious with our messaging in our IEC, that we don't really try to stigmatize sexual mode of contact.
Thank you very much, sir, for enlightening us, and thank you for the efforts that you're taking to empower the HRG groups for early reporting, and also to assess their risk of the clients coming to them and all, and also for telling us about how the actions are taking place at the STI clinics or the Pullaries, and also the efforts that you're taking to closely or very carefully create IEC so that stigma is avoided. Thank you, sir, for joining us once again. And shall I move to our next panelist? We have Anuja Madam, the professor and head of the Department of Dermatology, seen how challenging it is to diagnose a case of monkeypox with the cases without skin lesions, and the cases are reporting to surgeons and all those things. And we see that there are reports that we do not see the classic prodrome, which could be less severe, and the characteristic vesicular lesions may not be there, and the genital lesions are also, as we saw when Arvind presented, that 60% of them had genital lesions and all. So it is very challenging. So we would like to hear from you, madam, how can we actually make the diagnosis, or how can we overcome these challenges of diagnosis? And secondly, the question is, what is the importance, or how important is it for an interdisciplinary team to act in the management of monkeypox? I know that for the first case, there was an excellent teamwork at Medical College, Tirunelveli. Okay, over to you, madam.
Thank you, Senior, and thank you all the team and organizers for inviting me to this. The first question is about the atypical presentations, and as all the other speakers have already pointed out, now we know that especially this current outbreak, there are a lot of atypical presentations. Especially you have seen what Dr. Arvind was pointing out. Even though the classical presentation is with the prodrome and lymphadenopathy, followed by the skin lesions, especially on the face, which then spreads centrifugally. In many of the cases now presenting, they present with genital lesions. So actually in our case, which presented to Trivandrum, the first case in India and Southeast Asia, the patient had presented with lesions on the genitalia and on the oral cavity. And soon after, maybe in a day's time, he also had developed a skin lesion. So we have to have a very high index of suspicion to make a diagnosis like of monkeypox. But especially in the first case, we had this history of coming from UAE. So, and he was also giving a history of having been in contact with another suspected case of monkeypox who was a sexual partner. But many of the cases now may not present with the facial lesions, which is seen classically. They may present with the genital lesions because 95% of the cases now present, have a history of a sexual contact. So that may be the reasons why the genital case lesions and the oral lesions are more prominent. So atypical presentations with genital lesions and rectal lesions or perianal lesions may be more common, which may even come along with present as proctitis. They may not have the prodromal features of fever and myalgia, and some of them may not even have the lymphadenopathy, which is said to be the classical differentiation from smallpox and chickenpox. And sometimes they may not have this the skin lesions, which are said to be very prominent. But in our case, also we had just a few lesions, less than 20 lesions, which we had counted. And these lesions will not have the centrifugal spread and the localization to the extremities and the face because they were so discreetly and very sparsely and very spaced out lesions on the body. And sometimes they may even will not have any skin lesions at all. So we have to have a very high index of suspicion. And in fact, we have had, I think, if I'm right, we have had about 7 or 8 cases of suspected monkeypox, and only one turned out to be positive, and the others were actually herpes gingival stomatitis, and I think 50%. I think we had about 4 cases who presented as chickenpox. The problem now is everybody is now concerned, and especially since these patients present to the dermatologist, we are all trained and sensitized. So we always think of the possibility of monkeypox in any case that presents with vesicles and papules on the body. So that's why all the chickenpox cases, all the other 4 cases of chickenpox were suspected to have, were doubted whether they had monkeypox, and were isolated, all the red channel and the isolation, and then they were sampled to confirm for monkeypox. And then we have had 1 or 2 cases, I think one pediatric case of HFMD, hand, foot and mouth disease, and one patient who was actually a Nigerian patient who had come to the Sri Chitra, and she was probably having only insect bite reaction, but she presented with erosions. And because of the epidemiological link of having come from a foreign country, especially from the African country, she was considered to be having monkeypox. So we all have to, I think we can only depend on our clinical suspicion, and most of us, especially dermatologists and the infectious disease department people and the general medicine people, are highly trained to diagnose chickenpox. But however, especially with they have an epidemiological link, we should definitely consider monkeypox. So the atypical presentations have to be kept in mind, and we have to depend on our clinical acumen also. Now, Senior, the second question was on whether we have to have an interdisciplinary approach. Definitely yes, especially with the other presentations in Kerala itself. One had presented with the inguinal swelling, one had presented with encephalitis. So definitely the complications of monkeypox can be pneumonitis. If it affects the lungs, it can be encephalitis. It can have eye complications leading to even blindness. It can have complications if it is in a pregnant woman, if she can transmit it to the babies. So a gynecological consultation. And so definitely the question about interdisciplinary approach, definitely that is very pertinent. We have to have a teamwork with the pulmonary medicine people, the infectious disease people, of course, they go without saying they are part of it. And the neurologist, the gynecologist, the pediatrician, everybody has to be involved to come to a correct diagnosis and conclusion, and of course, go forward with the management. I hope I'm clear and I've cleared the questions. Dr. Senior?
Yes, madam. Thank you very much, madam, for sharing your experiences and views and telling us. We take it from you that the clinicians have to have a very high degree of suspicion, and the job is not easy. And thank you very much, madam, for sparing your valuable time with us. So, can I move on to the next panelist, Meenakshi madam? We have heard all along that there should be change of surveillance strategies, including the case definition. And so my question to you, just restrict to one question because of a shortage of time, madam. My question to you will be, what will be the state surveillance strategies ahead? Presently, we know there are a lot of strategies, but what are our plans ahead, considering the changes that we have seen, that there are cases without epidemiological link? We have seen that there are a lot of asymptomatic cases as well. And we see that there are cases without skin rash, and there are changes of case definition. So we continuously be needing to disseminate all these case definitions and strategies. So what are the plans ahead for the surveillance of monkeypox in the state? And also we have heard from Himanshu sir that we need to have surveillance, targeted surveillance in high-risk groups, about which Ramesh sir has spoken. But at present, I think we are focusing ourselves on hospital-based surveillance restricted to some of the clinics. So how do we expand this surveillance and this media scanning and all those things? How do we incorporate all these things?
Currently, we are focusing on targeted surveillance itself. That is hospital-based surveillance and also targeted surveillance. Hospital-based surveillance means the dermatology clinics, STD clinics, as Ramesh sir told, no? Then the medicine, pediatrics, OPDs, and also the casualty. That hospital-based surveillance is the first one. And the second is the targeted surveillance. As Ramesh sir said, we have the targeted intervention groups and the MSM and the FSW population. So they'll be targeted. Regarding the case definition and all, I think this central surveillance unit, they will consider the our request. That is, Dr. Aravind has clearly told, no, the deceased case, he has no lesion, so no rash. So that definition we may have to change, and also the atypical presentation. So that we will have to, and currently we are focusing the hospital-based isolation of patients, and probably in the coming, when caseload is becoming more, we have to adopt the home-based care also. But currently we are focusing on this hospital-based treatment, and also the suspected contacts, they are also isolated in hospitals, and the samples are being taken, and according to the results, they will be released from the hospital isolation. And we have sent 72 samples till date, and out of that only 5 positive cases, and 63 samples were turned negative, and 4 samples we are waiting for the result. All were imported cases from UAE, and we are now focusing, the samples are being taken from all these chickenpox cases, few of the samples from chickenpox cases, and also HFMD cases, and that is also being tested at NIV Alapi. And we have currently Trivandrum Medical College and the State Public Health Lab also doing this lab surveillance, that is testing. So we'll expand the surveillance, lab surveillance also.
Thank you very much, madam, for your elaboration of the present strategies and the strategies that we'll be adopting in future. And a big salute to the surveillance team for picking up those cases, because we have only imported cases and perhaps no cases without an epidemiological link. It means that we have been able to pick up cases like early there has been no transmission, or there has been no transmission that has been going on. That is a very applaudable, and also a big salute to the people of Kerala for reporting as early as possible. We have not had any cases among the contacts. Thank you very much, Madam, for joining us. Madam is always with us, and she's been a member of the panel for all these updates. Thanks once again. And next, just three more panelists to go. And shall I ask the next question to Nanda Kumar, sir? My question to you, sir, is what is the need and possibilities of surveillance among animals in monkeypox, and how do you think we can do it in the state of Kerala?
Yeah, at the outset, let me thank the organizers, Intimam and Dr. Sinia, for inviting me for this particular session. In fact, first I felt like, I was a fish out of water because I'm not sure whether I can fit in for this particular discussion, but I think there is an animal component involved. In fact, I thought, I'll just convey what all I think about this particular disease in animals. In fact, in the present scenario, I think I heard from one of the speakers telling that, now it's not a monkey issue because it started from monkeys in Africa, but now it's been all around the world, like, in Europe, in India, and now it's in Kerala also. And here the present the context, if you take, animals are not really involved in the transmission of the disease and the spread of the disease. But definitely, if at all there's an animal component involved, we should be really careful about it. Because, normally the animal host involved in this particular disease would be non-human primates and also rodents. Rodents, particularly the Sciuridae, like, the squirrel group of family. The squirrel group of rodents is a primary host which can directly get transmit the disease to human beings. Of course, primates, if you take, you have these macaques and langurs, the normal monkeys, what you see, but they don't work in the interface of human beings. Just for people who work who live in the forest fringes, like tribal settlements, and people who just move out in the forest, they only have an exposure with monkeys. But if you have pets like but we don't have prairie dogs here. Prairie dogs are nothing but ground squirrels. And luckily, we don't have such things yet. But now it's a time, people start rearing exotic pets too. So we don't know which all pets are being reared by people. And if at all you have an exposure, like, the normal symptoms shown in animals would be, again, respiratory signs and also pock lesions, just as you see in human beings. So almost similar lesions you can find in animals. And if you have a pet and if you have close contact with those infected animals showing these signs and these clinical symptoms, probably you'll have to keep aloof from them, or take precautions by wearing your proper gear, and also cleaning and disinfection and all those practices what you do in a hospital to get rid of infection or to keep the infection at bay. So that is what you can think. And I think I heard Dr. Prakya referring about buffalo pox, and buffalo pox and these orthopox viruses is not a new virus in animals, because we have got this camel pox, this cow pox, and all these pox virus infections very common in animals. But these manifest in animals as only, whereas in cow pox in animals, that happens in milkers. When they milk the animal, these pox lesions are normally found in the udder and the teeth. And when they milk the animals, they get some nodules in the hand, just like small pustules in the hands that you call as a milker's nodules or the milkman's nodules, milker's nodules. So that is not that's a benign type of a lesion, and it just gets cured, or it just heals off on its own without getting any problem, without having any problems later on. And certainly, if you want to do some surveillance, I don't think it's not the time for an animal surveillance. And if at all you feel like, I think you are the people who has to tell us whether we should be undertaking some surveillance, if at all, which all species to be to target, and what are all the actions we should be taking from our side. We are definitely more than happy to help you all, because it's a zoonotic event, and me being in a profession like veterinary doctor, working with animals and working with wildlife too, I'm at an increased risk, and I'm very happy to hear this session. I've been hearing, so a real learning session for me, and I can propagate this message to my people in my profession, so that this comes to as an education for my profession, and also the public whom we handle. And this is what I can tell from my side at this point of time. And Madam, if you want anything else to add, I can just ask me. I can explain further.
Thank you very much, sir, for warning us on the possibilities of these exotic animals coming in and the trend and all those things, and also telling us, offering a hand of support and telling us that you'll be there with us if there is any requirement. Of course, there are a lot of unknowns in the disease, and Vinod sir has been telling us about some silent transmission that could have been ongoing. So maybe at any point we have to be alert. Next, Manjusri Madam, the professor and head of the Department of Microbiology at Government College College. Could you share your experience on how the lab was established so that the others who take on later, when there's a need for more labs, will be helpful to them?
Thank you, Dr. Indu and Dr. Senior, for inviting me to this session. And it has been a great pleasure and experience of being part of the investigation team of the first case of monkeypox from GMC Trivandrum, Kerala, India. It's the first case. And the medicine department and the ID, ENT, surgery, dermatology, community medicine, and the ped cell microbiology department in the medical college level, and the state level, the DSO, ADHS, and non-COVID doctors, and worked as a team to for the confirmation of the first case of monkeypox. It was a team effort, and ICMR has given us training for the monkeypox laboratory testing and PCR and all to 15 VRDLs, and that was in the last week of June 29th. And fortunately, we were among them as the VRDLs. And exactly 2 weeks after this training, we got the first suspected case of monkeypox. Later turned out to be confirmed by ICMR as positive. And so because of this training, we can easily get into this team. And we actually, after getting proper instructions and guidance from the ICMR team, we could be able to collect the samples in a proper way and pack and transfer to NAV Pune. So all the samples are sent to, all the samples were found to be positive also. And the samples are transported to NAV through IDSP. So we are very grateful to the ICMR team and the IDSP for helping in all the support throughout this venture. Our VRDL became one of the first ICMR designated laboratory for doing monkeypox testing. That was from August 1st onwards. And we got, usually the Trivandrum GMC got samples from southern districts of Kerala. And so far, there are 16 samples. All of them were found negative, as from the already described by Dr. Pragya and Dr. Aravind also. And apart from our VRDL, 3 more VRDLs are also trained. It is, I think, Trishur, the VRDL, and Alapi is also there, and Manjeri and State Public Health Lab. So that's all that experience.
Thank you, Manjusri Madam, for sparing your valuable time. It's great to know that the proactive role that ICMR took in training the VRDLs even before we could get confirm the case. So that gives us the confidence that we will be able to manage any disease, probably any such disease that will come to us. And our last panelist is Dr. Gina Ramesh. I'll just restrict to one question. So at the institutional level, Gina, could you tell us what are the challenges that we are facing in surveillance of monkeypox or in general surveillance?
Thank you, Indu Madam and Zinia Madam, for involving me to this list of panelists for the current round of updates. Now, one of the strengths of Kerala is the strong disease surveillance system, which is a backbone for a sound public health system in the state. Now, there are a few obstacles that I personally came across when it comes to data retrieval and data sharing. And one is at the system level, where usually we tend to get multiple Excel sheets. This is in general, not in case of monkeypox alone. So we tend to get multiple Excel sheets and Google spreadsheets, which are sent in a time-bound manner from all medical colleges. And this is sent to the DHS as well as the DME. Now, a unified surveillance system at the state level, which can be accessed by both the DHS and DME institutions, could be a solution, which could actually save a lot of time and resources, especially when we have limited access to internet facility in our institution. Secondly, the issue that we usually see is the need for streamlining data from isolation wards to the respective ped cells. Because many of times, most of the data that are to be entered are rarely made available. So it becomes a tedious task. And hence, I think timely training of the staff nurses and other staff, along with the management of the cases, they should be trained even regarding the importance of data sharing. which is important for surveillance, for a strong surveillance backing. Thank you, madam.
Is in full swing, perhaps we may get over some of these issues. So that is the end of the panel discussion. Thank you very much for giving me this opportunity, and thanks to each and everyone in the panel for the beautiful discussion.